Okay, next up we have Dr. Barry Platnick. Dr. Platnick is a board-certified general surgeon, surgical critical care, surgical intensivist, and palliative care medicine physician. Dr. Platnick is the director of the surgical trauma ICU at Denver Health, where he puts his skills as a trauma surgeon and a palliative care doctor to work, taking a whole-body approach to the care of the injured patient. Dr. Platnick is also a Deadhead and has attended over 100 Grateful Dead concerts with Jerry Garcia.
All right, well, thank you for that. And you can infer from that depending on the policy that you have at the hospital, I actually qualify as a geriatric trauma patient if I get injured. And I also want to say that, when I'm older, if I'm not allowed to drink, smoke, or have caffeine, that is antithetical to my goals of care. Okay, so let's just be clear about that. So I'm going to see how this works. The title is Primary Palliative Care for Surgical Intensivists, and I think it said Pain and Palliative Care on the schedule, which sort of sounded like Pride and Prejudice, and I didn't really know what to do with that. So where you see surgical intensivist, insert yourself. Think of yourself, because I think what I'm going to talk about pertains to being a good provider, clinician, bedside practitioner. So first of all, who's here? By show of hands, pre-hospital? Great. Nursing? Providers? RT, recreational therapy, music therapy, physical therapy. Yeah, great. Okay, so another thing I want to do just by show of hands, because this is my public service piece, how many people here have a designated medical durable power of attorney written down on paper for everyone to see? Okay. And how many people here don't have that, but they have somebody who would make medical decisions for them if they lacked capacity? For all of you who don't have it written down here in the state of Colorado, anybody can come in and be considered an interested party and take place in the identification or becoming your proxy. So in the state of Colorado, there's no hierarchy. It's not like next of kin or anything like that. So if you don't have somebody written down, that disenfranchised sibling in California might just come back and either pull the plug or leave the plug in, depending on who you are. Disclosures, I have no financial disclosures. I am a trauma surgeon and have been for decades, and I'm also a palliative medicine physician. And so the reason I say that is because a lot of what I'm going to talk about is, for lack of a better term, touchy-feely. But the truth is, in the ICU, we are trying to save lives. And that's what I do. I take care of people who've been shot, I take car wrecks, all that. We are trying to save lives. And what I'm hoping to impress upon you is that is not mutually exclusive from what I'm talking about today. Man, do I sound really loud to you? Okay, because I sound loud to me, which is unusual. I usually sound loud to you. Okay, so here's the objectives. I'm going to talk about primary palliative care, and hopefully you'll understand what I mean by that when we're done. I also want to talk about when is specialist palliative care beneficial, because we'll talk about the fact that there's a difference, and I think of palliative care as a skill we all have, and yet sometimes we have to call consultants for some of the work we're doing. The concept of total pain, which is not new, but maybe new to some of you, is something that I want to spend some time on. I also want to talk about the interdisciplinary team, and with such a large contingent of nursing, I'm hoping that a lot of you are already familiar with that. And I'm hoping that by the end of this, you'll agree that palliative care is fundamental, and it's fundamental in the treatment of trauma patients, critically injured patients, and all patients. The other disclosure I have to make is that I can't see the notes for my slides, and I tend to get very tangential, so I'm going to try to stay on track here. This is my dog Potter, okay? So insert in your mind anybody or any pet you love dearly. And imagine them imagining a beautiful vacation. And they're going to go on this lovely vacation. And they go to a travel agent, and that travel agent goes ahead and sets up the vacation. the destination, the itinerary, and everything. But they don't ask them where they want to go, what they want to eat, who they want to be with, what language they want spoken. Suddenly, that vacation is not so much fun, and they're afraid, and they're nervous, and they're anxious, and they're scared. Well, this is kind of what I think of for our patients who come in injured or critically ill in our ICU. This is what we do to them. I'm not saying that they come in expecting, the vacation in the tropics, but I'm pretty sure this is not what they're thinking about, okay? They're hoping to come in and be treated kindly and lovely and tenderly, and we tie them down and we drug them and we do what we do, right? And we do that in the interest of saving their lives, and a lot of what we do needs to be done. And I want to come back to that over and over again, that we are here to save people's lives. I like to go to this statement because I'm a surgeon, and the American College of Surgeons, nearly 20 years ago, called out palliative care by creating a statement of principles. And the reason I do this is because palliative care is not just an internal medicine or family medicine kind of thing. It is everybody's job. What I love about this is, we go through dignity on autonomy and the right to choose and communication, and these are the basic principles that we kind of embody in taking care of the whole patient. Psychological, social, spiritual issues. One of the two of the things that I really appreciate is the physician or provider's responsibility to discourage non-beneficial treatments. And I think for us in the ICU, especially when we're taking care of patients that are being taken care of by a number of different specialties, it's important for us who have the understanding, hopefully, of the goals of care of the patient to recognize whether treatments are goal concordant or not. And so the ability to encourage or discourage non-beneficial treatments is important. And lastly, I like number 10, because only the American College of Surgeons could say to surgeons, play nicely in the sandbox with others. And it's true. I think one of our jobs is to support that interprofessional communication. Come on, wrong button. So, what is palliative care? Some of you know, some of you think you know, some of you don't know. Is it the death squad? Is it just the morphine team? Is it just who we call when we want to get a DNR? I think many people think that's the case. Is it who we call to do nothing once we've done everything? A lot of people resonates with people. Is it all of the above? Well, no, it's obviously none of the above, right? Or I would be taken down by the palliative colleagues sitting in the chair in front of me. So I like this. Yeah, this is not what we do. It may be part of what we do, but it's not what we do. Okay, what palliative care is not, and let's start there. It's not a death sentence or the death squad. And in fact, when you consult palliative care for patients in the ICU, it either has no change on mortality or it actually decreases mortality. And I think that's one of the misconceptions. You call us in, and we're going to smoke your patients, and that's going to be the end of it. It's not just comfort care. It's not end-of-life care necessarily. And we're not the addiction medicine team, and I want to be clear about that. A lot of times people think palliative care, we've got somebody who's got a drug problem, let's call them in. We may be helpful in that setting, and we'll talk about that possibility, but that's not really the role of the palliative clinician. It's most definitely not mutually exclusive with life-prolonging care, okay? We deliver them side by side, and that's a take-home message from this, is that early palliative care consultation and aggressive treatment go together, and there's no reason they shouldn't. It's not just getting the DNR or the proxy or the POA, although it may be. For those of you who don't have an MD-POA and find yourself lacking capacity in our ICU, palliative care may help fend off that antagonistic sibling. And it's not the sequel to failed care, and I want to stress that as a second point. I think it's a common misconception that we call palliative at the end. The earlier we can get palliative care involved, the better the team gets to know the patient, the family, and the more help we can be. So what is palliative care? And I highlighted, obviously I put in yellow what I want you to remember. It's an approach to suffering. It's a multi-dimensional approach to suffering, not just pain as we think of it, and we'll talk about total pain, but suffering as a whole. It's an interdisciplinary field, and it uses multiple specialties, and we'll talk a little bit more about what I mean by interdisciplinary. We also think of the disease burden and the burden of treatment, and that's part of how we help patients understand what is goal concordant for them. In other words, what they may or may not want, and help them achieve that. And it can be delivered along life-prolonging care. For clarity, okay, because I think hospice and palliative care get mixed up a lot. Palliative care is a form, hospice is a form of palliative care. So the idea is still the same, the alleviation of suffering, decrease the burden of disease, but it's delivered with the intent of solely alleviating that suffering and without the intent for life-prolonging care. It's delivered typically to people who have 6 months or predicted prognosis of 6 months or less. It can be delivered in the home, it can be delivered in some hospitals, it can be delivered also in inpatient settings. Hospice care, comfort care, withdrawal of life-sustaining treatment, those are not doing nothing, and in fact, in many cases, that's doing more for the patient. So what is primary palliative care? What do I mean by that? Primary palliative care is what everybody here should be able to do a little of, okay? It should be able to be delivered by the intensivist, the trauma surgeon, the APP on the service, pretty much everybody who's involved in taking care of the patient. We should be able to have the basic goals of care conversations, right? That's not something that necessarily needs to be relegated to the specialist. We should be able to coordinate and conduct some family meetings. Identification of surrogate decision makers, again, the antagonistic sibling. Identification and understanding of advanced directives. It's important for us to know what they are, what they mean, what the value is of them, because that is the patient's wishes when the patient had capacity. It's the provision of appropriate interdisciplinary services. In other words, we don't necessarily provide the service, but we have it, we know where to get it for the person, and I'll show you more about that here in a little bit. And then symptom management. So I think all of us do some form of symptom management to varying degrees with different levels of expertise, from reassurance, which is a form of symptom management, to ketamine infusions. Wrong button. If I flash you in the eye with this laser beam, I'm sorry. So not to give short shrift to physical symptoms, I just want to point this out. This is the symptom burden of chronic critical illness. So for people who've been in the ICU for 7 days or more, you can see that about 2/3 of them experience and report unsatisfactory treatment of their symptoms, ranging from dry mouth to dyspnea. And in fact, nearly 2/3 of patients who are on a ventilator, being rested on the ventilator. So why do we put them on the ventilator? We put them on the ventilator because they can't breathe. What do they feel when they're on a ventilator? They feel like they can't breathe. So clearly there's a lot of work for us to do, and sometimes the symptom burden is such that specialist palliative care or specialist symptom management, maybe it's anesthesia pain service, that is involved in bringing in the people necessary to treat the symptoms. And so I don't want to give short shrift to the symptom burden, the physical symptom burden. And in fact, for your patient in the ICU, it may be the nausea that's their most burdensome symptom. Okay? So when I ask what suffering means to you, what comes to mind? And you can either, if you're feeling bold, you can shout it out, or you can just have it come to mind. So no talk would be complete without a word cloud. Yes? Yeah, very much so. So again, that would be goal disconcordant. And we'll talk about that here in a little bit, but that can be a great source of burden or discomfort for the patient, the family, the treatment team, everybody, okay? The comment was one thing that could be suffering is when the family wants to keep the patient alive and the patient doesn't want to be kept alive. So you can see here when you look at this word cloud, suffering is a very multidimensional phenomenon, right? It's not just, stubbing your toe hurts, but you stub your toe and then you're angry at yourself and you wish you'd fixed the thing and you can't believe you did that and you tripped over your dog, whatever it is, it involves psychological, social, spiritual domains, and it is kind of where everything comes together for us. And again, the surgeons finally got it together and they put out a statement that the control of suffering is of equal importance to the cure of disease in some cases. And so I think that that's important for us all to recognize as we start, dragging people through things they may not want. So, which of these do you think might contribute to total pain? And I'm going to be embarrassed because one of them is, you'll see, it speaks to the... So, obviously, total big burn, total pain. Severe brain injury contributes to total pain. Rule out neck fash and ground level fall consults all night. So that's fine. For us as trauma surgeons, that's not what we live for. We take care of them and we do it well. But for us as trauma surgeons, the big bad is kind of what we like. Updates to the EMR, everybody, if there's total pain for anyone, that's it. You hear there's going to be an update tomorrow, you come in, it's got new colors and everything's in a different place. None of the above? Actually, no, all of the above, right? Depending on who you are, all of this contributes to the concept of total pain. This is not a new concept. It was developed really early on in the sort of creation of the concept of palliative care. And it's the intersection of the physical, psychological, spiritual, and social domains. The physical domain, I think we're all pretty comfortable with. We recognize, right, that the injury or the disease causes physical pain. We may be a little less recognizing that the interventions cause physical pain, and it doesn't have to be that we're doing surgery that causes physical pain. It just may be rolling the patient. It may be cleaning the patient. It may be putting an IV into the patient, right? The comorbid conditions that they come in with cause physical discomfort, certainly, whether it's congestive heart failure, COPD, rheumatoid arthritis. These cause physical pain. They may have dyspnea, nausea, vomiting, etc. And so this is the physical domain. And we treat this and we try to treat it well. Sometimes we don't understand why our treatments are not working. And that's kind of where total pain happens. The social pain, think about the financial concerns of this person who's in your ICU or critically injured or ill, the burden of the hospital bill, they're not able to work, they can't make their house payments, loss of role or social status. It's going to be a little bit difficult to get right back up on the slopes if you've lost a leg, for instance. It's going to be difficult maybe to be a public speaker if you're disfigured. You may lose your job, they may have lost their job, or they may be looking at losing their job. Worried about the family welfare, for that person who's dying, what's going to happen to my family? How are they going to be taken care of? And legal concerns, right? Do I have my affairs in order? So now you've got somebody who's suffering physical pain, who's worrying, okay? And we've started to kind of, as you can see, they're starting to overlap. That same person who's having physical pain, who's worrying, who's losing potentially their job and doesn't know who's going to take care of their family, has the basic anxiety of what's going to happen next. Their fear of suffering, right? Maybe they're coming in to do the wound vac dressing change again, and the last time was just so much pain and they didn't treat my pain well, and so I'm worried about that. Underlying depression, I imagine that many of our patients have some level of situational depression associated with their injuries. Previous experience with trauma or illness. Now, I don't know about here in Boulder, but I can tell you in Denver, at Denver Health, a lot of our patients have been there before, Trauma is a chronic disease with a high recidivism rate. Loss, as we spoke to before, and then again, depending on what happens, guilt, shame, and denial, right? A lot of the patients who come in for trauma especially, they may have been complicit in that trauma. It may be alcohol related, it may be texting related, maybe it's lung cancer and they've got the association of having smoked, alcoholic liver disease, and they're just trying to cope. So we've got a patient with severe illness and injury who's suffering massive physical pain, who's looking at losing their job and no one's going to take care of their family, and they fear of the person coming in and doing more to them, having had this before, and we're freaking out a little bit about the fact that they did this to themselves. And now there's a spiritual component as well, and it doesn't necessarily mean religious, right? What I mean by spiritual is simply that. It's that aspect that can be somewhat intangible, that sort of describes how we make meaning out of our existence. And that anger may be at the universe or at God, however we might express that. Maybe if it is religious, there's a loss of faith. That struggle to find meaning, like how could this have possibly happened to me? Fear of the unknown. I'm facing death. I'm facing paralysis. And the fear of divine repercussion, which is not uncommon for people of faith, is that there may be, especially in the afterlife, there may be some repercussions, or even in this life, there may be repercussions for the actions that they've taken. And that simple loss of dignity. So again, when we start working with people who are spirits who are suffering, and we are treating their pain, simply going in and upping the dose of Dilaudid may not be the right answer. And sometimes we have to spend a little time with them to figure out why is it that the medications aren't working? What is it that they need? And you can see as I talk about this is not just me going in and taking care of this patient. It's not just you going and taking care of this patient. It's us taking care of this patient. It's us as a group working together towards a common goal, and that's the definition of interdisciplinary. Forgot that swelled. So just a couple comparisons between primary palliative and specialty palliative, because there are times to call the specialist, right? I'm a trauma surgeon. I'm a surgical intensivist. I work in the ICU. I take care of people who have cardiac contusions and myocardial ischemia, and they have AFib, and we treat all that. But when I don't know what's going on, I call a cardiologist, right? When it gets to be beyond my scope. I take care of patients with decreased renal failure, decreased renal function, acute kidney injury, electrolyte or abnormalities. When I can't figure out what's going on, they need to go on dialysis, I call the nephrologist, right? That's what I do. And so the same thing is true for primary and specialty palliative medicine. Basic pain management, all of us. Basic pain, basic management, other physical symptoms, nausea, little Zofran, right? When the nausea is unrelenting and maybe there are some other medications necessary or non-medical integrative therapies, we need to call for specialist palliative care. When I say specialist palliative care, I'm referring to the skill set, not necessarily a person. We do we may be pretty good at converting between opioids, but for the complex patients with refractory pain, refractory symptoms, patients who are on methadone who maybe need transition between methadone and other opioids, depending on your hospital and who you have in your resource tool bag, it may be the palliative care team that helps with that. Sometimes patients with addiction problems and serious illness, so that's not an uncommon situation. So you've got somebody who has serious illness, who is a patient that may be seen by palliative care, who also has addiction issues, and that can be difficult to manage side by side. This is sort of the total pain piece. All of us should be able to manage basic depression and anxiety, and that's really may just be reassurance, right? Or maybe it's a little bit of medical therapy. Exploration of psychosocial suffering, that can be as easy as how you doing, okay? And then a little silence, and we'll let them respond. What's your religion? Can I help you with that? Can I help you find somebody for that? It doesn't mean that I have to sit down and preach, although I stand up and preach, it appears. It doesn't mean that I need to pray with somebody, but I do need to know how to get the right people to the place to help with that. And that's part of my job as a primary palliative care skill set card-carrying physician. The specialty team, however, that's for managing more complex treatment. And that specialty team might be a psychologist, it might be the chaplain, it might be the social worker. It may be somebody actually that the patient formed a connection with previously that is none of those, but is the best person to be at the bedside for this patient. And then serious illness communication issues. I think all of us who've been in this for a period of time are reasonably good at helping the patient explore goals of care in terms of what's going on. You know, what would you like me to do for you? Making recommendations about code status, and I want to stress that for the people who do make for the providers in the room. It's unfair to explain to somebody what's going on and say, hey, so what do you want me to do? I mean, sometimes you just have to make a recommendation. And the way to do that, at least the way I like to do that, is to ask for permission to make that recommendation with the patient. Because we do this not infrequently. We do it, you know, we do it in kids a lot with PD. We explain everything to the parents and then say, well, what do you want us to do? Instead of making a recommendation, putting really a significant burden on either the patient or the family. So that was a side preach. Seeking consensus, whether it's among the treatment team or the family, we all do a little of that, but when the wheels start to come off the bus, or you think the wheels are gonna come off the bus, it's time to get that's when you get a palliative care consult, right? When the family, you've got one family says, keep them alive, one family says, let them go, and then you've got the kid's 20 years old, and then there's the 4 other kids that he's been living with for the past 2 years who say, well, actually, no, we know him the best. So there's an opportunity there for some referee work, and that may be your palliative care specialist. Patients who want everything done, again, that's a sort of a classic difficult patient. Patients who invoke the miracle, right? I'm waiting for a miracle. That needs to be explored. That doesn't necessarily, it can be difficult for us. And so maybe we're not the best people for that. Maybe that's interdisciplinary. Maybe it's chaplain, social work, nursing. One of the things we have in Colorado is requests for assisted dying in terms of medical aid in dying, but we also get that elsewhere with the request for hastened death, whether that's voluntary cessation of eating and drinking or liberation from life-sustaining treatments like compassionate extubation. One of the things that I think palliative care does that goes unrecognized and certainly unreimbursed is helping the team deal with and work with the fact that patients make bad choices. And it's hard for us. It's hard for the whole team, whether it's the physicians, APPs, nursing, respiratory therapy, the physical therapists. Patients make bad choices, and it promotes moral distress, and I think some of what palliative care does is just help with that. So, remember this, we got the total pain thing here. And you can see, does this go backwards, we think? Yeah. So you can see from this that this is a complex diagram, and it's a complex diagram because humans are complex. Suffering is multidimensional. And when we get a patient in the hospital, you know, we don't get a gallbladder, we don't get a femur fracture, we get, you know, a somewhat older trauma surgeon who was driving too quick to get to the talk this afternoon who wrecked his car, right? And so who's taking care of this person? There's really 2 teams. There's a multidisciplinary team whose function is to work independently to provide their expert skill set to achieve their specific goal in the treatment of this patient. And we need that, right? We need a neurosurgeon to take care of the brain injury, orthopedics to take care of the fractures, trauma surgeons to manage the whole patient, critical care intensivists to manage the patient in the ICU. The interdisciplinary team, however, is a group of professionals who all have their own background and training and their own specialties, who are working together towards a common goal. They're not working, the social worker's not just working towards necessarily the social goal or the religious goal for the chaplain. They're working towards this common goal of relieving suffering and the burden of disease. And so a team that works together, an interdisciplinary team, for the common goal of alleviating the suffering of the patient is an interdisciplinary team. And that is palliative care in a nutshell. It's that group of individuals who are providing that additional layer of support for the patient as they work through the serious illness or injury. So I just put this patient up here just to kind of walk through it and see if this makes sense. So you've got a 54-year-old male involved in two-car motor vehicle crash, and there was a single fatality in the other car. Do we start thinking that maybe this person's going to need more than an orthopedist? So who might they need? They might need a chaplain, they might need a social worker, they might need friends or family. And part of the job is to figure out what they need for that. This same person has multiple facial fractures. They ruptured their right globe. They don't have a brain injury, but they've lost an eye. Multiple rib fractures with hemopneumothorax and a chest tube, and a right upper extremity crush pending multiple operative interventions. So again, who might this person need? Other than they need an ophthalmologist, they need an orthopedist, they might need microvascular hand surgery for the work on that arm. So they need a multidisciplinary team to manage their injuries. However, if we look down further, this person lives in Colorado, so they may or may not be a hiker, but they're a high school history and social studies teacher. They are the baseball coach for their high school team. They're divorced, probably live alone. They have 2 adult children who don't live here, and he's a recovering Catholic. Okay, somebody might relate to that. So you've got a patient now who has this rich history and this rich life, who's potentially looking at being blind in one eye, who is currently in severe thoraco or thoracoabdominal pain, and who may or may not use their arm again. This is somebody who I would submit early involvement of an additional layer of support of an interdisciplinary team to help this person through their hospital course may be of greater value than a lot of what we think of traditionally when we take care of patients. Oh, and he has prostate cancer. So he came in already worried about dying or peeing, one of the two. So, again, I want to stress for the group that total pain is a real and multidimensional phenomenon. Interdisciplinary teams are in my mind, are the key to managing that level of suffering for a person who's injured. And if you look at in the middle, there's always somebody's loved one, okay? And it's important to remember that we're not just taking care of the broken femur, we're not just taking care of the head injury, we're taking care of the person. So, palliative care is not restricted to those at the end of life. It should be delivered alongside of life-sustaining treatment. Pain is not a unidimensional phenomenon, and it requires an interdisciplinary team to manage it. And we, the surgeons, I think, because we're at the forefront of trauma care, we need to create a fundamental culture change where inadequate treatment of this level of suffering for our injured patients is unacceptable. And it's unacceptable to, if somebody gets a pneumothorax from a central line, we jump up and down and scream and we review it, we send it to peer review and try to figure out what's going on. But if somebody suffers through their entire hospital course, we may not even know about it. So there you go, that's what I got. Questions? Any questions or comments? You thought it was that good, huh? Well, hopefully when you take care of people, you have some heart in that. one of the things that I like to say to the residents and my partners is if this job doesn't make you cry from time to time, you're either a bad person or you are not paying attention. So, thanks.